Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 12th episode of Optometry Series 2.0. I'm very happy to welcome my team members, Ms. Anshika ma'am. Hi ma'am, thank you so much for joining, and hi Meenakshi. Thank you so much for joining once again. And Anshi ma'am, so another new day, another episode. So what is today's topic and who's our today's moderator, ma'am?
Okay, so today's topic is very interesting, the small part of the eye, which is the pupil, and we're going to read about and learn about its anatomy and its diseases. And today we have someone very special, Sheeba. She's my classmate, and I'm very happy that she's a part of today's moderation. Thank you so much for accepting, Sheeba. And I think without much further delay, we'll start. Can we have the introduction of our moderator? Divya, please start.
Good evening, one and all. I am Divyadharshini, a third year Bachelor of Optometry student at Dr. Agarwal Institute of Optometry. It gives me great pleasure to welcome our moderator, Ms. Sheeba Swarna. Uh, Sheeba ma'am is a guest faculty at the University of Hyderabad with over 10 years of experience in clinical, academic, and program management roles within healthcare and research. Ma'am has completed her master's in optometry from the Elite School of Optometry, Chennai. She has also served as a senior optometrist in the field on contact lenses, a clinical researcher guiding a postgraduate student in research, and a lecturer in various esteemed optometry institutions, including the University of Hyderabad, SRM Institute of Science and Technology, JIPMER, and the Elite School of Optometry. Thank you for joining us, the moderator, ma'am. Now I am delighted to welcome today's presenter, Ms. Renuka, a second year Masters in Optometry student at Dr. Agarwal Institute of Optometry. Ms. Renuka, please begin your presentation.
So good afternoon all. Topic is about pupil anatomy and diseases. So first, let's see the introduction. So pupil, it is often referred as the gateway of light. It is a deceptively simple structure with profound clinical significance. So pupil is nothing but it is a small hole which is located in your center of the iris, which allows the light to strike the light. Next, the light enters through the eye, and iris regulates the amount of light by controlling the size of pupil. So as you can see in this picture, it consists of sphincter muscle and radial muscle. So the iris is categorized into two groups of smooth muscle, which is of circular group and radial group. So the circular group is called the sphincter pupillae, and the radial group is called the dilator pupillae. So in circular group, what happens is there will be a parasympathetic control which is responsible for constriction, and in radial group there is a sympathetic control which is responsible for dilation. So what happens when the sphincter pupil contracts, the iris will constrict the size of pupil. Similarly, when the dilator pupil is innervated by some sympathetic nerves from the superior cervical ganglion, what happens is there will be a dilation that will make contract. These muscles is referred as intrinsic eye muscles. In this image, we can see pupil constrict as a circular muscles of iris, which is contracting, which is a parasympathetic nerve, and this is under bright light condition and normal light pupil. And in dim light, what happens is the pupil will dilate as a radial muscle of iris in which it will contract, which is a sympathetic nerve. Next is the, so if the drug pilocarpine is administered, the pupil, what happens is it will constrict, and the accommodation will increase due to the parasympathetic action on the circular muscle fibers. Conversely, atropine will also cause the paralysis of accommodation of cycloplegia and dilation of pupil. Next, we will see about the anomalies of pupillary reactions. So it consists of afferent pupillary defect, oculosympathetic palsy, which is the Horner syndrome, and another one is Aedis pupil. So first, we'll be seeing about afferent pupillary defect. So what happens there means there will be a complete optic nerve lesion, and it will be characterized by these following. So first, there will be involved eye will be getting completely blind. So both pupils will be in equal size, and the near reflex intact will be there. So when affected eye is stimulated, neither pupil will react. When the normal eye is stimulated, both pupils will react normally. Next is relative afferent pupillary defect. So this is RAPD, which is caused by an incomplete optic nerve lesion or severe retinal diseases. Here, the clinical features are those of an amaurotic pupil, so where there will be no there will be a incomplete optic nerve, and the pupils will respond weakly to the stimulation of the diseased eye and briskly to that of the normal eye. So here we can see the difference that can be highlighted with the help of the swinging flashlight test. So next, RAPD can be categorized by the following. This is under no light, and when there is a normal response to light, and when there is a positive RAPD of right eye. So when the normal eye is stimulated, the pupil, both of the eye of the pupil will get constricted. When the light is swing in the shine in the diseased eye, both pupils dilate instead of constricting. What happens there is there will be a dilation. When the normal eye is again stimulated, both eye pupil will constrict once more. When the diseased eye is stimulated, both the pupil will dilate. Next, we will be seeing about oculosympathetic palsy, which is nothing but the Horner syndrome. So, the sympathetic supply involves three neurons. So, one is of central, preganglionic, and postganglionic. So, first is of central neuron. What it does is it initiates the sympathetic outflow from the brain to the spinal cord. Next is preganglionic. So, here what happens is it relays the signals from the spinal cord to the peripheral ganglion. Next is postganglionic neuron. So in postganglionic neuron, what happens means the final ray to the target structure will affect in the eye and the face. Next signs is majority will be unilateral and mild drooping of the eyelid will be noted, which is of mild ptosis, and there will be a meiosis in dim light, and we can note the hypochromic heterochromia, which is in which heterochromia is also classified as total heterochromia, sectorial heterochromia, and partial heterochromia. So the pharmacological test we do is cocaine 4% instilled in both eyes. So the result will be normal pupil will dilate, whereas the Horner syndrome will won't dilate. So next we will be seeing a new condition which is ADIS pupil. So it is caused by the denervation of the postganglionic supply of the sphincter pupil and the ciliary muscle, which may follow a viral illness. So it will be affecting mostly in the young adults, and it will be also a unilateral condition. So usually what are the signs that we will note in a ADIS pupil condition is first there will be a large and regular pupil. We will be seeing in the upcoming slides about the direct light reflex. So direct light reflex is also absent or sluggish, and consensual light reflex is absent or sluggish. There will be a slow pupillary response, and it will be associated with the tenton reflexes and the autonomic nerve dysfunction. So we have other abnormal reactions also, which includes physiological anisocoria. So anisocoria is two pupil will be unequal in size. In dim light, the right pupil will be larger than the left. In bright light, what happens means both the pupils will constrict normally. Next is right pharmacological mydriasis. So in mydriasis, in right mydriasis in dim illumination, in bright light, the right pupil will not constrict. Next is Agile Robertson pupil, so which is caused by neurosyphilis and are characterized by these following. So first, in dim light, both the pupils will be small and may be irregular. And same as in bright light, neither pupil exists. On accommodation, both the pupil will get constricted. So next we will be seeing about the measurement of pupil size. So first is simple scale and pupil gauge method, and next is pupilometer method, which consists of Habs and Sanders. So in simple scale and the pupil gauge method, you can see the scale over here, a manual tool with printed circles ranging from 1 mm to 9 mm. So it will be very quick and inexpensive and also portable. Next is HAPS pupilometer. So it is a mechanical device which is calibrated with the horizontal scale. So what happens is we will measure two things. One is of pupil diameter and another one is IPD. So we have to ask the patient to look straight ahead while the examiner aligns the scale with the pupil edges. Next is Sanders pupilometer. So here it is a more advanced optical pupilometer which is including the binocular viewing and also the illumination control, and it also records the IPD for accurate lens fitting. So next is results of measuring the pupil size, physiological anisocoria and pathological anisocoria. So in physiological anisocoria, typically that will be less than 1 mm difference in the diameter. Normal variation in the pupil will be difference will be the difference in between the two eyes. So next is pupil shape and location and number. So normal pupil will be in circular shape. So here we have two conditions. One is correctopia and another one is polychoria. So in correctopia, what happens is that it will be referring to a congenital abnormal placement of pupil. Whereas a normal pupil will be placed slightly nasal to the center. And another one is polychoria. As you can see here, it is a rare congenital anomaly where there will be more than one pupil. Next is pupil color. So usually the pupil color will be like a grayish black. If suppose in case of aphakia, it will be like a jet black color pupil, and in cataract that will be grayish white, and white reflex will be noted in leukocoria that will be seen in congenital cataract, retinopathy of prematurity, and retinoblastoma, and yellow reflex will be seen in endophthalmitis. And in different types of cataract, like a cortical cataract, the appearance will be pearl white, and if it is a hypermature cataract, it will be in milky white color, and if it is a cataract brown color, and it is cataract brownish black will be noted in cataract nigra. So now let's see the tests that are done for the pupil reflexes. So first, we'll be classifying as direct light reflex and indirect reflex. So first is direct reflex. So here, the reaction of the pupil to the light will be shine in the same eye. So we have to ask the patient to sit comfortably in a dimly lit room. So what we have to do is we have to ask the patient to fixate on a distant target. Why? Because to avoid the accommodation. Then we have to hold a pen torch or any trans illuminator from the side. Then we have to shine the light into one eye. Then we have to observe the constriction of the same eye's pupil. So this is termed as the direct light reflex. So next is indirect light reflex. So here what happens is there will be a reaction of pupil on the opposite eye when the light is shine in one eye. So we have to keep the patient in the same position, still fixating on a distant target. So same procedure, shine the light. Here we have to shine in only one eye. Then we have to observe the other eye pupil. So pupils of the opposite eye always should constrict simultaneously. So this will indicate the reflex is a indirect reflex or the consensual reflex. So next is near reflex. So we have to ask the patient to look for distance and check for the constriction. Same as a patient to fixate on a distance target about 6 meter. Hold a near object like a pen tip or a finger about 15 to 20 centimeter in front of the patient's eye at a midline. So here the main three components of triad comes into play, which is of convergence, accommodation, and meiosis. So in convergence, that both eye will move inwards, and in accommodation, lens thickening will happen. And lastly, meiosis, there will be pupil constriction will be happening simultaneously. So swinging flashlight test. So it assesses the integrity of the effect of the visual pathway and mainly to assess for relative afferent pupillary defect, as we discussed earlier, and aid is pupil under normal light condition and poor response to light and when there is a slow accommodation. Ne- Next is Horner syndrome. So clinical triad, which is of due to the interruption of sympathetic pathway. So here also we have a triad, which is ptosis and meiosis and anhidrosis, where there will be a loss of sweating on the affected side. Next is Hutchinson pupil. So here there will be a fixed dilated pupil which is caused by the compression of oculomotor nerve, which is due to herniation. So clinically what happens here is there will be a rise in the intracranial pressure. Next is amerotic pupil. So here the pupil will be abnormal due to the complete optic nerve lesion. The features will be including light reflex, indirect light reflex, and the near reflex. So here amerotic refers to the blindness. So you can see in the picture of normal eye and the contralateral pupil constricted, whereas the blind eye contralateral pupil not constricted. So here we have a mechanism which is of the afferent pathway that is from the retina, which reaches to the optic nerve, then it enters the pretectal nucleus where it will be absent. Next, but the afferent pathway from Edinger Vespa nucleus, it will be reaches to the oculomotor nerve and it will enters into the sphincter pupillae, which will remain intact. Thank you.
Thank you so much, Renuka. Yeah, thank you so much. It was an elaborative presentation. Now I request the moderator to add your valuable inputs, ma'am.
Renuka, it was a very good presentation.
And
The
sorry to
explanation.
interrupt. Renuka, can you please unshare your screen? Yeah, ma'am. Yes, sorry to interrupt.
Okay. Renuka, it was a very good presentation, well prepared. I have two questions to you. So in your slide, you said anisocoria, right?
Yes, ma'am.
What is anisocoria, Renuka? Like when do you say it's
Mm.
anisocoria?
When there is a difference between the pupil size.
Okay. So you said two classification, right? Physiological anisocoria and pathological anisocoria.
Yes, ma'am.
How do you differentiate whether it is physiological or pathological during your pupillary examination?
Based on the mm,
So can you elaborate more?
if it is typically less than 1 we can say it is a physiological anisocoria.
Okay, so basically anisocoria, we have to evaluate the pupillary size both in dim illumination as well as in
And
bright illumination. Okay, so when you compare the pupillary sizes both in dim and as well as in bright, the anisocoria is same, then it is physiological anisocoria. If the pupillary size is increasing in dim or in bright, then there is some pathological condition, some lesion sitting in the pathway that is causing the change in the pupillary size. Okay. So that's how you differentiate during your pupillary examination itself, whether it is a physiological anisocoria or a pathological anisocoria. Okay. One more question. You said polychoria, right? What is
yes, ma'am.
polychoria?
There will be more than one pupil.
Okay. So suppose you get a patient who has two pupils. And how do you do refraction?
I don't know, ma'am.
So generally, whichever pupil is sitting in the center, okay? So you choose that pupil and you shine light through that hole, okay? So they say, suppose you have central one hole and there is eccentrically another hole. We generally prefer whichever the pupil that is in the center of the cornea so that your refraction is stable, okay? Fine. Other than that, you have covered extensively. Good
Thank
job.
you.
Thank you so much, ma'am. There are a few questions from our student side also. I'll read it for you, ma'am.
Okay.
One question which you have already answered. They have asked the differentiation between physiological and pathological anisocoria.
Okay.
We have answered that. The second question is what red flag signs in pupillary evaluation will suggest an urgent neurological referral?
That Renuka has already explained in the presentation. It is the RAPD. Or RAPD or is the first red flag. Whenever you see an RAPD, they require a immediate neurological examination. During our pupillary examination itself, we will do color vision to make sure that our optic nerve and the visual pathway is safe or not. Okay. Other than that, anisocoria, yes, but it might not be not an emergency, maybe a secondary to RAPD.
Thank you so much, ma'am. The next question is can pupillary findings alone help in diagnosing lesions in visual pathway?
Not 100% we can say. It will help the optometrist to come to a differential diagnosis based on the patient history, whether they have any visual pathway defects or not. Okay, so based on the pupillary examination, you will decide to do your visual field test also. You can do your maybe visual field test and color vision test. Based on this, we can decide whether the patient needs further examination or not.
Thank you, ma'am. And the last one is, what is the common mistakes that you feel the students are doing while performing pupillary evaluation?
So this has been taught to us in college days. It reminds me the experiences that we had during our bachelor days. So basically, we when we used to practice in our clinic or in our hospital, we have torchlights. Okay, generally we prefer we should take a bright torchlight which doesn't have a central scotoma. That is a very, very important thing. You have to choose a good torchlight, and then you should make sure that the room is dark. It is should not be completely dark that you don't identify the pupil. Where is the pupil? So what you should do is keep that muscle light on in your Snellen chart, or the Snellen chart itself. You can dim, keep the lowest illumination, and then you can use your torch. Um, pen torch is not advisable because it is not that illuminated. So the normal big torch you can use, or if you have IDEO available at your practice, you can use IDEO. And then while doing RAPD, you have to be quick in swinging the light. Okay, you should be as quick as possible to check the other eye response. So other than that, nothing else. You should make sure the patient is not looking at the light and he's looking at a distant target.
Thank you so much, ma'am. That's all the questions from student side. Anshi, ma'am, do we have any questions for our moderator, ma'am?
No, I think both Renuka and Sheeba covered a lot. So, very good presentation, Renuka, and thank you so much, Sheeba, for bringing out the nuances of how a pupillary evaluation should be done. It is very important. Anybody can shine a torchlight, but it's important on how quick we do it if you're doing a swinging flashlight, or where we are positioning the torchlight,
Yes.
not exactly front and not exactly at the side. So those positions are also very important when we want to do a pupillary evaluation. And as pointed out, if you see an RAPD, please make sure that in emergency situations we do, send the patients for a neuro evaluation and we don't miss up. So it's very, very important to even keep practicing pupillary evaluation, even if it's on normal people.
Yes.
Otherwise, it's very difficult to even find out a very minimal RAPD grade also. So thank you, Sheeba, and thank you, Renuka, so much for bringing about all the important points of pupil anatomy and pupil diseases. Over to
Thank you. Thank you for this opportunity. I thank the Agarwal Institute for giving me this opportunity to moderate this session. Thank you, Anshika, and your team. It was a great session.
Thank you so much, Sheba, ma'am. We'll also like to thank you and we'd like to host you on another wonderful platform in the near future, ma'am.
Sure, sure.
Thank you so much, ma'am.
Thank
Thank you,
you.
Anshika, ma'am, for roping in Shiva, ma'am, today. And Meenakshi, thank you so much for your support as always. Renuka, excellent presentation. Best wishes for your future. Dear audience, thank you all for your continuous support towards Optometry series. The announcement for this particular week is Pan India internship opportunities are open at Dr. Agarwal's Institute of Optometry. Please refer to please click on the website link given in the description box, or call the number that has been attached in the description box. The another exciting announcement for this particular week is the registrations are open for ISVTech conference, which we are doing along with collaboration along with the Loyola ICAM College. So, which is coming on October 24th and 25th. This is going to be an exciting, one of its kind conference. So, don't miss this opportunity to participate. The link for the registration will be given in the description box as well. Thank you all for your continuous support. Meet you all in the next episode. If you like this video, give a thumbs up and share with all your optometry friends. Meet you all in the next episode. Thank you, ma'am. Thank you, Shiba, ma'am.